There is an assumption that most adults carry into every medical appointment, one that feels so obviously correct that it rarely gets examined, that more medical testing is always better, that finding something early is always an advantage, and that a screening test that identifies a problem gives you more options and better outcomes than never knowing about it. And this assumption is true, clearly and importantly true, for many of the most valuable tests in medicine, from blood sugar monitoring to blood pressure measurement to cervical cancer screening in the appropriate age groups. But it is not universally true. And after 60, in specific contexts and for specific screening tests, the evidence from large studies involving hundreds of thousands of adults tells a different story. A story in which a screening test finds something that would never have caused any harm, and that finding sets in motion a sequence of further tests and procedures and treatments, each carrying its own risks, that collectively produce more harm than the original condition would ever have generated on its own. Doctors call this the cascade effect, and it is one of the most important and least discussed concepts in medicine for adults over 60. I want to be precise about what this video is and is not. It is not a recommendation to avoid medical care, to refuse any specific screening, or to assume that finding problems is dangerous. It is a framework for understanding why some specific screenings in specific populations at specific ages have evidence profiles that suggest a more careful, individualized conversation with your doctor is warranted before proceeding, rather than simply accepting every routine screening offered as automatically beneficial. Before anything else, what I share in this video is educational information only. It is not medical advice. Every screening decision should be made in conversation with your own physician, who knows your personal history, your risk factors, your values, and your preferences. The goal of this video is to give you the specific language and the specific questions to make that conversation more informed, not to substitute for it. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The most important shift I try to make in every conversation about screening with patients in this age group is from what does this test detect to what does detecting this thing actually do for this specific person, given their overall health, life expectancy, and values. Those are different questions, and the answer to the first one does not automatically answer the second. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what actually helps you after 60, and this video may be one of the most practically useful ones I have ever made. Let me start with the concept of overdiagnosis because it is the mechanism behind most of what I am going to discuss, and because most adults have never had it explained clearly. Overdiagnosis means the detection of a real condition, meaning a condition that is genuinely present and is not a false positive, that would never have caused harm, symptoms, or death during the person's natural lifetime. The condition is real, the test finding it is accurate, but the detection itself does no benefit, because the condition was never going to matter. This sounds counterintuitive. We are accustomed to thinking of cancer diagnoses as always life-threatening, of abnormal test results as always dangerous, of detecting something as always better than not knowing. But cancer is not a single disease. It is a spectrum of biological behaviors. Some cancers grow rapidly, metastasize early, and kill quickly if not treated. These are the cancers that screening can save lives from, by detecting them before they have spread. Other cancers grow so slowly that, in an older adult with a life expectancy of 15 to 20 years, they will never produce symptoms or reduce lifespan. A person dies with them, not from them. And detecting these slow-growing cancers through screening leads to treatment, and treatment carries risks, and the treatment risks produce harm in people who would have been fine without ever knowing. The clinical term for this is length-biased sampling. Screening programs tend to preferentially detect the slow-growing cancers because fast-growing ones often appear between screening cycles as interval cancers, and because slow-growing ones have a longer detectable preclinical phase during which a screening test can find them. The result is that many of the cancers and conditions that screening identifies are the ones least likely to have been the cause of any problem. Understanding this is the foundation for the 5 conversations I want to have. The first area where the screening benefit-risk balance shifts meaningfully in older adults is prostate-specific antigen testing, the PSA test, for prostate cancer detection in older men. The biology of prostate cancer is a near-perfect illustration of the overdiagnosis problem. Prostate cancer is the most common non-skin cancer in men, And autopsy studies have consistently shown that between 30 and 70% of men over 60 who die from unrelated causes have prostate cancer present in their prostate gland at the time of death. It was there. It was never the cause of their death or their illness. It was a biological reality that would never have become a clinical problem. The PSA test detects elevated prostate-specific antigen in the blood, which can reflect the presence of prostate cancer. It has genuine utility in specific circumstances. In men with strong family history, in men being monitored after a previous prostate cancer diagnosis, and in men who have considered the trade-offs and made an informed decision to screen. The problem is not that the test is invalid. The problem is that an elevated PSA in a 72-year-old man often triggers a biopsy, and the biopsy can itself cause complications including infection, urinary problems, and occasionally sepsis. If the biopsy finds a low-grade, slow-growing cancer, the subsequent treatment options of radical prostatectomy or radiation therapy carry significant risks of permanent erectile dysfunction and urinary incontinence, while multiple studies have found that men with low-risk prostate cancer who choose active surveillance, meaning monitoring without treatment, have outcomes indistinguishable from those who chose immediate treatment, while sparing themselves the side effects. The United States Preventive Services Task Force recommends shared decision-making for PSA screening in men aged 55 to 69, acknowledging that for some men, the potential benefit outweighs the risk. For men over 70, the task force recommends against routine screening because the potential harm from overdiagnosis and treatment becomes more likely to outweigh the potential benefit, particularly in men with other significant health conditions. The conversation to have with your doctor is not, should I ever have a PSA test? It is, given my age, my overall health, my family history, and my values around the potential trade-offs of treatment side effects versus cancer detection, what does a shared decision-making conversation about PSA testing look like for me specifically? Type in the comments right now if your doctor has ever walked you through the specific trade-offs of PSA testing, rather than simply ordering it or not ordering it at your routine visit. Because the quality of that conversation is one of the clearest measures of how shared the decision-making actually is. The second area is mammography in older women, specifically in women over 75, where the benefit-risk calculation shifts in a way that is rarely communicated clearly. Mammography has saved lives. For women in their 40s and 50s, the evidence for mortality reduction from breast cancer screening is well established, despite legitimate debates about the magnitude of that benefit and the degree of overdiagnosis that accompanies it. For women in their 70s and beyond, the calculation is different, and the reason is not that breast cancer in older women is less dangerous. It is that the lead time from screening to benefit is long, and that in women with limited life expectancy from other causes, the detection of a slow-growing breast cancer through screening may initiate a treatment pathway that produces more harm than the cancer itself would have. A study published in the Journal of the American Medical Association found that in women over 75, a significant proportion of breast cancers detected by mammography were of the type that grew so slowly they would not have caused symptoms or death in the woman's remaining lifetime, even without treatment. This proportion increased with age and was highest in women over 80. In women over 75 who are otherwise in excellent health with a life expectancy of more than 10 years, continued mammography may be appropriate. In women over 75 with multiple significant comorbidities and a life expectancy below 10 years, the argument for continued routine mammography is substantially weaker because the treatment initiated following a cancer detection would need to be completed and provide survival benefit within a window shorter than most treatment benefit timelines. The conversation to have is, given my current health, my life expectancy, and the statistical reality of what mammography in my age group detects and what it leads to, is annual screening the approach that best serves my well-being and my values? That is a question most women over 75 have never been invited to ask. It should be standard. And share this video right now with one person in your life over 70 who attends screening automatically without ever having had a frank conversation about the specific benefits and harms at their age and health status. You may be giving them the framework for a conversation that genuinely serves them. And if you are not yet subscribed to this channel, tap that button now and ring the bell. The third area concerns colonoscopy frequency and the decisions that follow it in adults over 70 with no prior polyp history, normal previous colonoscopies, and no symptoms suggestive of colorectal disease. Colonoscopy is one of the most impactful cancer prevention tools in medicine. For adults in their 50s and 60s, colonoscopy both detects and removes precancerous polyps in the same procedure, genuinely preventing colorectal cancer rather than simply detecting it. This preventive effect is established, and the evidence for colonoscopy in appropriate screening populations is strong. The more nuanced question concerns colonoscopy in adults over 70, particularly those with normal prior colonoscopies, no current symptoms, and multiple significant other health conditions. Colonoscopy in older adults carries procedural risks that are higher than in younger adults. The risks associated with bowel preparation in those with cardiac or kidney conditions, the risks of sedation in adults with cardiovascular or respiratory disease, the risk of perforation, which increases with age and with the technical challenges of operating in an older colon, and the risk of post-polypectomy bleeding. A study published in JAMA Internal Medicine found that in adults over 70 with a prior normal colonoscopy, the rate of finding advanced colorectal neoplasia at follow-up screening was low enough that the procedural risks and the life expectancy considerations together shifted the benefit-risk balance away from routine 10-year repeat colonoscopy in adults with significant comorbidities. The American Gastroenterological Association recommends that screening decisions in adults over 75 incorporate a life expectancy assessment, recognizing that adults with less than 10 years of life expectancy do not have sufficient time to benefit from cancer prevention that typically requires 10 years of lead time to manifest as survival benefit. This is not an argument against colonoscopy. It is an argument for individualized decision-making that considers each person's prior colonoscopy history, their current symptom status, their overall health and life expectancy, and their values about procedural risk versus cancer detection. The person with no prior colonoscopy, new bowel symptoms, or significant risk factors is in an entirely different category from the person with consistently normal colonoscopies, seeking a routine repeat screening in their late 70s with multiple comorbidities. The fourth area concerns cardiac stress testing in adults over 60 who have no cardiac symptoms, no chest discomfort, no unexplained breathlessness, no exercise intolerance, and no significant change in their cardiac risk profile, but who are offered or request a routine cardiac stress test as part of a comprehensive health check. In symptomatic adults, stress testing is valuable and important. In adults being assessed before high-risk surgery, stress testing provides meaningful prognostic information. In adults with known coronary disease being monitored for progression, stress testing has a role. But in asymptomatic adults with a low to moderate pretest probability of significant coronary disease, the stress test has a false positive problem that is clinically significant. No test is perfectly specific. A stress test, like any test, produces a certain proportion of false positive results in the population being tested, meaning a result that appears abnormal but does not reflect actual coronary disease. In a population where the underlying disease prevalence is low, such as asymptomatic adults with moderate risk factors, the false positive proportion of all abnormal results is substantially higher than in a symptomatic population. The test is applied to a group in which most abnormal results do not represent real disease, and yet each abnormal result triggers further investigation. The further investigation of an abnormal stress test in a low-risk asymptomatic adult typically leads to coronary angiography, an invasive procedure that carries a small but real risk of stroke, heart attack, arrhythmia, and bleeding at the access site. If the angiogram finds coronary narrowing, that was the cause of the false positive appearing stress test, it often leads to stent placement, which commits the patient to dual antiplatelet therapy with its bleeding risks, and which in stable coronary disease without symptoms has not been shown in randomized trials to reduce the rate of heart attack or death compared to optimal medical therapy alone. The American College of Cardiology and the American Heart Association do not recommend routine stress testing in asymptomatic adults at low to intermediate risk. The test, ordered routinely in the absence of symptoms, generates a cascade that serves the detection of a problem better than it serves the health of the person being tested. The conversation to have is, I have no cardiac symptoms. What is the evidence that a stress test in someone with my specific risk factor profile would produce more benefit than harm? That question, asked specifically, requires a specific evidence-based answer. If you are not yet subscribed to this channel, Tap that subscribe button now and ring the bell because every week I come here with exactly this kind of specific, evidence-grounded information that makes your medical conversations more effective. I want to tell you about William, 67 years old, retired accountant from Seattle, Washington. He came to me after what he described as the worst 6 months of his life, despite having felt perfectly well at the start of it. It began with a routine executive health check. He had no symptoms. His ECG was normal. His blood pressure was managed. Cholesterol was treated. On the advice of the executive health program he had paid for, he had a resting ECG and a cardiac stress test as part of the comprehensive package. The stress test showed a borderline abnormality in the inferior wall. His cardiologist recommended coronary angiography. The angiogram identified a 50% stenosis in the right coronary artery, a narrowing that is anatomically real, but that falls well below the threshold at which coronary intervention is typically indicated or proven to be beneficial. However, the finding generated a discussion about whether this borderline narrowing was the cause of the stress test finding, and ultimately a stent was placed. The stent placement resulted in a small area of myocardial infarction from a side branch that was inadvertently compromised during the procedure. William spent 3 days in hospital. He was started on dual antiplatelet therapy, which he continued for 12 months, during which time he had a significant gastrointestinal bleed, requiring hospitalization and transfusion. He was no better at the end of those 6 months than he had been before the routine health check. He was worse. His cardiac function was marginally reduced from the procedural infarction. His gastrointestinal tract had been damaged by the antiplatelet therapy, and the right coronary artery borderline stenosis that started the cascade would, in most clinical guidelines, have been managed with medication and lifestyle optimization, rather than stent placement had it been found in the context of symptomatic evaluation with a higher pretest probability. He told me, "I went for a health check because I wanted to make sure everything was fine." I told him, "What happened to you is one of the clearest examples of the cascade effect that exists in the medical literature. It is the reason that screening asymptomatic people with tests that generate false positives requires careful consideration of what those positives lead to." The fourth area is carotid ultrasound screening for carotid artery stenosis in adults with no neurological symptoms. Carotid ultrasound is an appropriate and important test in symptomatic patients who have had a transient ischemic attack or a stroke, and in whom identifying carotid stenosis guides urgent surgical or endovascular treatment to prevent a subsequent stroke. The evidence for carotid endarterectomy in symptomatic adults with high-grade stenosis is strong, and the risk reduction is meaningful. The evidence for carotid artery screening in asymptomatic adults is far more complex. The carotid arteries of older adults frequently contain atherosclerotic plaque, and a significant proportion of adults over 65 have detectable carotid narrowing on ultrasound that has never produced any neurological symptom. Finding that narrowing creates a management dilemma. The same surgical or endovascular intervention used in symptomatic adults carries its own risk of stroke from the procedure, and in asymptomatic adults, whether the intervention reduces total stroke risk compared to optimal medical therapy with statins, antiplatelets, and blood pressure control, is a question that the most recent randomized trials have not answered clearly in favor of intervention. The United States Preventive Services Task Force recommends against screening for asymptomatic carotid artery stenosis in the general population, concluding that the potential harm from the cascade of false positives, unnecessary procedures, and procedural complications outweighs the uncertain benefit. This recommendation reflects the current evidence and is based on the same principle. Finding something does not automatically produce a benefit, particularly when the treatment of the finding carries risks that may equal or exceed the risks of the untreated finding. If you have had a transient ischemic attack, a stroke, or any neurological symptoms, carotid evaluation is appropriate and important. If you are asymptomatic, the routine carotid ultrasound offered as part of a comprehensive health check deserves the specific question: given that I have no neurological symptoms, what does the evidence say about whether finding carotid disease in my situation leads to better outcomes or to a cascade of procedures? The fifth area is bone density scanning with DEXA and the management decisions that can follow from it, particularly the pharmacological treatment of osteopenia, the mid-range bone density category below normal but above the threshold for osteoporosis. Bone density scanning is appropriate and important in postmenopausal women over 65 and in men over 70 who have risk factors for fracture. Identifying genuine osteoporosis, particularly when combined with a FRAX fracture risk score that incorporates clinical risk factors beyond bone density alone, guides treatment decisions that reduce fracture risk in high-risk adults, and that benefit is real and documented. The concern arises specifically with the diagnosis and treatment of osteopenia, the category between normal and osteoporotic bone density. Osteopenia is not a disease. It is a statistical category that encompasses the bone density of approximately 50% of postmenopausal women over 50. Having a T-score in the osteopenic range does not mean a person will fracture. Most adults with osteopenia never fracture. Most fractures occur in people who are osteopenic, which is the arithmetic consequence of osteopenia being so common. The treatment of osteopenia with bisphosphonate medications, drugs like alendronate and risdronate, has genuine benefit in adults with genuinely high fracture risk, as defined by the FRAX score. But bisphosphonates also carry risks, particularly with long-term use. Atypical femur fractures, meaning stress fractures in the femur shaft, that are associated with prolonged bisphosphonate use, occur rarely but dramatically, and osteonecrosis of the jaw, while uncommon, is a serious complication associated with prolonged use. When a DEXA scan identifies osteopenia and leads directly to bisphosphonate treatment, without a FRAX fracture risk calculation, and without a discussion of the relative magnitude of benefits versus risks for that specific person, the treatment may be producing more harm than the bone density finding warranted. The more evidence-based approach to osteopenia in most adults is focused strength training and fall prevention, both of which address the actual event, a fall, that is required for most fragility fractures to occur, rather than simply the bone density number. The conversation to have after any DEXA scan result is, what is my FRAX score, and what does it suggest about the absolute risk reduction I would gain from medication versus the risks that medication carries? That question, asked specifically, produces a quantitative answer that allows a genuinely informed decision rather than a reflexive prescription based on a T-score category alone. Here is the complete framework I want you to carry away from this video. Screening decisions after 60 are not binary. They are not simply get this test or refuse this test. They are conversations that require specific questions, and those questions are, what is the probability that this screening will find something in my specific situation? What proportion of findings at my age and risk level represent conditions that would actually harm me versus conditions that would never have caused any problem? If a finding occurs, what does the evidence say about what that finding leads to in terms of further testing and treatment? What are the risks of that further cascade? And how do those risks compare to the benefit of the early detection we started with? The screening tests I described are not universally harmful. They are tests for which the benefit-risk balance shifts meaningfully with age, with the presence or absence of symptoms, and with the overall health and life expectancy of the individual being screened. The same test that saves a 55-year-old's life may produce net harm in a 78-year-old, not because the test is bad, but because the disease it finds is different. The treatment it leads to is the same, and the remaining time to benefit from that treatment is shorter, while the risks of the treatment cascade remain unchanged. The shared decision-making model, in which the doctor and the patient together review the evidence-based benefit and harm profile of a screening test for that specific person, rather than following a calendar-driven default, is the approach that produces the best outcomes across the widest range of individual situations. It requires the patient to arrive with questions. The questions in this video are a starting point. There is one more practical consideration worth naming. The healthcare system has structural incentives that favor screening. Screening programs are funded, promoted, and measured as quality indicators. A physician who declines to order a standard screening test or who initiates a shared decision-making conversation about its benefit-risk profile is working against the system's default momentum. This does not mean that individual physicians are motivated by anything other than your well-being. It means that the questions that prompt the individualized conversation will often need to come from you, because the default without that prompt is the calendar-driven screening recommendation. Your willingness to ask the specific questions I described is the mechanism by which shared decision-making actually occurs, rather than simply being aspirational. 4 things to carry away. First, overdiagnosis, the detection of real conditions that would never have caused harm, is a documented and quantified phenomenon in several of the most commonly offered screenings in adults over 60. It is not a theoretical concern. It is supported by autopsy studies, by population-level data, and by randomized trials that have followed large groups of screened versus unscreened adults for decades. Second, the cascade effect, in which one screening finding leads to further tests, procedures, and treatments that collectively carry more risk than the original condition warranted, is the mechanism by which overdiagnosis produces harm. Understanding the cascade is essential to evaluating any screening decision. Third, the specific questions that distinguish a calendar-driven screening decision from a shared decision-making one are: what proportion of findings in my age group represent conditions that would actually harm me? What does the treatment of a finding produce in terms of risk, not just in terms of detection? And how does my overall health and life expectancy affect the benefit timeline of any treatment initiated? Fourth, none of this means screening is harmful or that medical testing should be avoided. It means that the best outcomes come from individualized, evidence-based, value-informed conversations about each specific test for each specific person, rather than from the assumption that more detection is always better. You deserve those conversations. You have the right to ask the questions that produce them, and the medical system works best when patients arrive at appointments with the specific, grounded questions that transform a routine recommendation into a genuine shared decision. Share this video with one person in your life over 60 who attends every recommended screening without ever having had the benefit-risk conversation that these decisions warrant. And subscribe to this channel because every week I come here with one purpose: to give you the specific information and the specific questions that make you an informed partner in every medical decision that affects your health. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.